Hello, everyone. This is Dr. Andrew Heyman. I'm here on behalf of Da Vinci Labs for the Professional Education Series. Today, we will be speaking about stress and the immune-brain connection, basically the relationship between stress and neuroinflammation. I'm a family physician by training. I direct the integrative medicine program at the George Washington University. I'm also the Director of Academic Affairs for Metabolic Medical Institute and also the Chief Medical Officer for the Metabolic Code. This topic, I think, is incredibly important because it helps to reframe how we understand the complexity of the stress response and move us beyond the concept of adrenal fatigue into something, I think, more grounded in the science and draws on an enormous evidence base reflective of the ways in which how psycho-emotional stress interfaces with the physiological components of the stress response. So today we'll be evaluating the impact of cortisol on the nervous and immune system. We'll look at common illnesses in the context of low cortisol states in particular, and how flattening of the cortisol curve, or technically speaking, hypocortisolism, is not only a prognostic indicator of morbidity and mortality, but it also indicates the degree to which the stress response has become impaired. And then we'll review some clinical aspects. So this is a quote by Fouad Lashin. He's a very famous neuroscientist who was nominated for the Nobel Prize. And he writes that a human being is much more than the sum of blood, bone, and viscera. In the same way, each fragment of truth in itself is a lie. Therefore, the unintegration of scientific facts does not protect us against ignorance. And in the measure that we interrelate a greater number of fragments, the closer we can come to truth, although truth as an absolute is unattainable. And what he's talking about is this notion that the body is beautifully interconnected, that it's a system of systems. And as one part shifts, typically other parts shift as well. Now, this is not a notion that we typically see in conventional medicine. Oftentimes, we look at a single marker or single abnormality. We define that as a disease state reflective of pathophysiology, and there's a direct intervention for that. What Fouad was talking about is this idea that just because a marker is high or low doesn't necessarily mean that that's the problem and or something that needs to be treated clinically. So he was very interested in this concept of the ways in which the brain itself had direct influence over just about every bodily process. And sometimes what we're able to measure is really just the epiphenomenon or just an expression of a deeper, more fundamental problem. And I think the stress response itself is really reflective of this idea. So here's another quote. I like this quite a bit. It was written by Richard Seltzer a number of decades ago. He's a very famous surgeon poet who was describing an interaction that he had with the personal physician of the Dalai Lama, who had been invited to do rounds in a Boston hospital. And this was the first encounter truly of classical Tibetan medicine with Western medicine. And to me, it really reflects the interaction and differences between these two worlds, these two worldviews with respect to essentially an offshoot of traditional Chinese medicine versus contemporary biomedicine. And sometimes looking at another framework for how this system conceives of health and illness can sometimes give us greater insight into not just what to do with patients, but it also really changes how we think about health and illness as a process. And I think that this quote really reflects that notion that sometimes as we slip into a different way of looking at things, a different language, a different framework, it opens up new ideas and new solutions for us that we couldn't see otherwise because we're trained to look at the world through a single lens. So he writes, his eyes are closed as he feels for the pulse, and in a moment he's found the spot. And for the next hour he remains thus, suspended above the patient like some exotic golden bird with folded wings, holding the pulse of the woman beneath his fingers, cradling her hand in his. all the power of the man seems to be drawn down into this one purpose. And I know that I, who have palpated 100,000 pulses, have not felt a single one. And what he's viewing is this moment where the practitioner becomes intimately involved in the assessment process. And think about that. 3,000 years ago, they didn't have CT scanners, they didn't have EKG machines, they didn't have objective blood labs. And so there was this great emphasis on practitioners developing their sensory skills that over time, through meditative techniques, detoxification strategies, changing one's diet, performing movement therapies like Tai Chi and Qigong, taking special herbs, undergoing additional therapies such as acupuncture, one could begin to clarify their energy, enhance their awareness, and essentially evolve into the CT scanner, become the EKG machine. That as one opens one's mindfulness, we begin to see more information essentially coming off the patient itself. And so the approach in these traditional or classical healing modalities and systems really relied on all of the nuance that one could gather, all of the subtle information that a patient may be expressing, not just verbally, but non-verbally. And there was this great attempt to take those essentially data points and look for patterns, look for groupings of expression of symptoms and signs that would give the practitioner insight into what really is going on with the patient. So ultimately, it became a process of pattern analysis and pattern recognition. What they were, I think, globally doing is beginning to more holistically assess the ways in which various body systems would collect around an illness and express themselves as a subunit of physiology, essentially sort of a version of a clinical systems biology. And so I think there was some sort of recognition that the body does do this, that there is patterns of expression that give us some insight. And even though they didn't understand basic anatomy and physiology, they did recognize that there could be sort of a grouping of signs and symptoms, and that from a more contemporary perspective, what that really means is that these biological interfaces among and in between physiologic systems would begin to express themselves in relatively reliable and repeatable ways. And so the question then becomes, as we look at our patients, what lens are we going to use? Is it the traditional lens of scientific materialism and standard biomedicine, where we really see the body as a series of levers and switches and pulleys and bellows constructed in a very organic and anatomical way, where our interventions are designed to focus on discrete components of the system? Or on the left, do we see the body as an ecosystem, a system of systems, more like a plant, essentially? And do we apply strategies that nourish the individual and improve one's vitality and energy and potential? I think both frameworks are right, and both are powerful. The question, I think, practically speaking, is does the practitioner have the lenses, the frameworks to be able to slip between these ideas effectively and apply new treatment strategies in a way that better maps onto what might be going on with the patient? And once again, I think stress is a good example of this mind-body connection, where we're trying to pull together some of these notions of the older ways of looking at health and illness through traditional a framework, but making it very contemporary and utilizing objective measurements and tools. So to me, then, this gets at this notion of integrative physiology, examining multiple organ systems simultaneously, seeking primary causative factors driving complex biochemical abnormalities, utilizing treatment strategies aimed at restoring allostasis and reducing allostatic load. I will define those terms in a little while. emphasizing treatments that improve physiologic functioning while avoiding risk or harm, and applying this notion of an ecological model of medicine. So how do we begin to define this area more broadly? So everybody has stress. We know we have stress, and stress comes in a lot of different forms. It's not just this notion of psycho-emotional stress. We have metabolic or physical stressors that also influence the health of our metabolism, which in turn can even have impact on how we think and feel. And we know that the burden of stress economically is enormous. That a report in 2004 said that workplace-related stress had an annual price tag of $300 billion. This is something that we sort of pay lip service to, but we don't always, I think, understand the degree to which stress in its broadest sense has great impact on just about every illness we can measure. So it's responsible for 19% of absenteeism, 40% of job turnover, 10% of costs related to prescription drug plans, and 60% of workers' compensation. And stress itself has been estimated to contribute to 70 to 90% of all primary care visits, I think either as a primary factor or as a modifying factor. And as we get into the physiological aspects of stress, I think you can see why. So from an anatomical perspective, the adrenals are one of the major engines related to the physiologic components of the stress response. The adrenal glands sit on top of the kidneys. They're about the size of a nutmeg, and there's several components to them. There's the adrenal cortex, which is essentially the rind of the adrenal gland, which is responsible for producing aldosterone, cortisol, androgens, pregnenolone, and progesterone, and then adrenal medulla, which is the core of the adrenal gland, and this is where the stress-related neurotransmitters are produced, epinephrine and norepinephrine. So we have a neurologic component to adrenal function, and then we also have a hormonal component as well. And so the hormones themselves are placed in a context of their relationship to all of the steroid-based hormones, which start with the parent compound cholesterol, and then through a series of enzymatic conversions, we then are able to produce a variety of downstream hormones and metabolites, including the androgens, estrogens, glucocorticoids, and mineralocorticoids. So cortisol has a variety of functions in the body. It's only produced in the adrenal glands. It regulates protein, carbohydrate, lipid, and nucleic acid metabolism. It also directly elevates blood sugar and blood pressure, and it increases protein catabolism and inhibits protein synthesis. Now, think about that for a second. When you're under stress and the body starts pumping out a lot of cortisol, there's a reason why there are these secondary effects that occur. So you could imagine when you're facing a lion and you're trying to run away or fight this threat, not only does cortisol improve peripheral blood flow, enhance vision, turn on short-term memory, but it also is able to influence other bodily processes that are critically important for managing the activity around stress. So of course you'd want an elevated blood sugar, so you have a ready supply of glucose in the bloodstream to feed the skeletal muscle. In addition to that, we see increased cardiac output, as well as changes in the vascular system to improve blood flow again to critical tissues and organs. But we also see shunting away from non-critical functions. So of course, we see a decline in reproductive hormones because we don't need to reproduce when we're under stress. We see changes and decrease in gastric motility and digestive capacity because, again, it's not time to sit down and have a meal. Basically, the body is shifting into a sympathetic dominant state and turning on those vital processes while also moving away from parasympathetic tone and turning off those related systems. Now, one of the more important features of cortisol that I think, especially for purposes of this talk, is that it's our major endogenous anti-inflammatory. And so it makes sense that as cortisol levels go up, we see a suppression of IL-6, TNF-alpha, and CRP. This is important to note that, in fact, cortisol operates on a teeter-totter relationship with the immune system. Now, there are other consequences and shifts that occur in immune response as well. As cortisol levels climb, we see a predominance of Th2 activity, so individuals become more atopic. Mast cells are leakier, so we see higher rates of allergies and asthma and eczema. Conversely, as cortisol levels begin to fall through a variety of mechanisms, we also see a shift into Th1 dominance. So in hypocortisol states, patients are more prone to autoimmune illnesses and cancers. We see, as a result of elevated cortisol, decreased antibody production, as well as suppression of growth hormone. So there's a loss of anabolic drive and heightened catabolism. So not only do we see suppression of immune response and an alteration in the body's capacity to fend off infections, but also a diminishment of anabolic drive. So we lose our capacity to heal. As a result of elevated cortisol, there's also bone loss. This is through a variety of mechanisms. There's direct catabolism of bone, as well as excess lactic acid production, increases in gastric acid secretion, inhibition of production of nucleic acids, and mobilization of fatty acids. Now, the antidote in the body is to cortisol is DHEA. DHEA is an interesting hormone, and we used to think most of it was producing the adrenals. More recently, it's been described that the brain also produces DHEA as well. Not only does it serve as a precursor to sex hormones, and it's the most abundant hormone produced by adrenal, but it also activates endothelial nitric oxide synthase, which makes sense. So as an antidote, it helps to relax blood vessels, and it directly binds to NMDA and GABA receptors in the brain, and it lowers cortisol. So it is an antidote to the stress response. It's also anti-atherogenic. It lowers triglycerides, improves insulin sensitivity, promotes a sense of well-being, and it's extremely neuroprotective. So we're going to come back to this notion of the role of the brain in the setting of the stress response, because it is central to regulation of cortisol production. And one way the brain protects itself against the catabolic effects of cortisol is by raising DHEA levels. DHEA also protects the tissue and improves integrity and strength of that tissue. It has direct action to promote immune activity, and it promotes bone growth as well. And so there is this diurnal pattern by which these hormones are naturally produced when we're not under times of stress. So there are higher levels throughout the day, and then there's a decline in the evening to allow those proper shifts in the immune system, as well as the anabolic hormones. So at night when we're sleeping, we can rest and repair and regenerate the body. So it makes sense that our stress hormones are higher during the day, because we have to manage the stressors of daily life, but that we really want to be able to sleep deeply and to get into that rest and repair phase. But if our stress hormones remain elevated in the evening, for example, it makes it very difficult for people to migrate into that process. So stress itself globally then can be defined as allostasis, which is the ability to achieve stability through change, which is critical to survival. This is a concept that was originally defined by a wonderful researcher named Bruce McEwen out of the Rockefeller University. And he is a physiological psychologist who's been studying the stress response for 30 years. And he wanted to come up with an integrated model between the psycho-emotional aspects of stress and the physical aspects of stress. The stress system itself, the biological components, are designed to protect the body by responding with internal and external to internal and external stressors, by invoking the autonomic nervous system, the HPA axis itself, cardiovascular and metabolic systems, and the immune system. So allostatic load then is the price of accommodation of stress, the wear and tear that results from chronic overactivity or underactivity of our allostatic system. So basically, allostasis is the body's ability to absorb stress and return to a homeostatic, or even what we would consider homodynamic place, but that the load is the pressure itself. And the question becomes, does the body have enough metabolic reserve and resources and capacity to absorb those pressures and come back to balance? Or do these systems, either physically or psycho-emotionally, begin to break down? Does the load overwhelm those the bodily capacity? So beginning with stressors, whether these are mild or moderate or severe, it first begins with sort of an awareness of those things cognitively. So we have to decide, is the perceived stress a threat? And then what is our sort of stance towards that threat? Do we feel efficacious and ready to manage that threat, or do we have some helplessness built in? Are we vigilant towards that stress, or even hyper or hypovigilant? Now, how we respond to that stress is multiple. And that can be through behavioral responses, through the fight or flight reactions, and mediated through personal behaviors. So do we develop positive coping skills and emotional resiliency, or do we start reaching for alcohol and cigarettes and other vices that can be harmful to ourselves as we try and cope with this stress in maladaptive ways? So everybody has a different set of coping skills in that regard once the stress is identified. In addition to that, all of this is sort of mediated through individual differences that our genetic engine, our personal development history, and experiences that we've accumulated over the course of our life all help dictate how we manage that stress. We even know that in utero exposure to stress primes the stress response to hypervigilance and overactivity. Now, that's in the kind of psycho-emotional domain. At the same time, we have a variety of physiologic processes that also become upregulated, as I've mentioned. And they're designed to marshal those internal resources and help us have the energy to meet that stress effectively. So we turn on certain body systems and we turn off other body systems. But if the amount of allostatic load overwhelms our ability to adapt to that stress, we begin to see a breakdown. The breakdown could be in the way we cope and our emotional and cognitive functioning, and to the point where we begin to develop PTSD, for example, and or we see real harm that occurs to the bodily components of the stress response. Now, under normal circumstances, we should have a stress, and our stress levels go up, and then we return back to a baseline. That's how the system is supposed to function. We can also have lack of adaptation, where over time, with repeated exposures to stress, the body begins to diminish in its capacity to respond to that stress for a variety of reasons, which I'll get into. Interestingly, there's also a group of patients that will have a sustained or prolonged response to stress long after the stressor has not only occurred but gone away, that the body never really returns to a baseline. This is important to understand so that even if the stress is historical, the body can continue to be upregulated, and this can have ongoing damaging effects as a result to various components of our health and well-being. And then finally, we can have an inadequate response overall, that once we lose adaptation and we've soaked up those metabolic reserves, then we can see where individuals just don't have the capacity to respond to stress anymore. This is a very important concept to understand, which I will go into in detail. Now, how do people get into these abnormal stress states? Well, there is no one single mechanism. There are several theories, and I think certain ideas in particular that are probably central to how we injure and ultimately damage the stress response and end up in a position of lack of adaptation. But there's a variety of processes that contribute to abnormalities in cortisol levels and ultimately our inability to marshal a stress response. I will say, when you look at the literature, and this might be a surprise to some of you, there is very little to suggest that ongoing and overwhelming stress ultimately damages the adrenals. That this notion of adrenal fatigue is highly unlikely. That in fact, it's nearly impossible to waste the adrenals as a result of stress. So the notion that low cortisol levels reflect low adrenal function really is a misnomer. And I think that it's under certain circumstances even a dangerous idea, because it can lead us to make incorrect assumptions about why is it does this patient have low cortisol, and then what do I do about it? So I think that one is really important to understand, because the central mechanisms by which people end up with low cortisol often have very little to do with adrenal function itself. Now, on the other hand, we can see reduced biosynthesis or release of these central regulating neuropeptides and hormones that participate in the HPA axis itself, like cortisol releasing factor, arginine vasopressin, ACTH, and cortisol itself. We can see hypersecretion of secretagogues with downregulation of target receptors. So you can actually get sort of a peripheral cortisol receptor resistance. We also see enhanced sensitivity to negative feedback of cortisol, very similar again to cortisol receptor resistance, decreased availability of free cortisol, so cortisol binding globulin levels can climb, and then reduced effects of cortisol on target tissue. So the tissues become less and less responsive to the presence of cortisol. So just like our notion of hyperinsulinemia and insulin resistance, there are features of abnormalities related to cortisol levels that really have to do with target tissues, target tissue receptor changes, as well as centrally mediated abnormalities. Now, maybe the most important idea, though, with respect to cortisol levels, I think is this slide. This relates to what's called the neurodegenerative model of hypocortisolism, basically the relationship between the brain and the stress response. And there's an area of the brain in particular that's considered the master regulator of the HPA axis. And it's one that doesn't get a lot of attention. So it's called the hippocampus. And the hippocampus has more cortisol receptors than any other area of the brain. And the hippocampus has several functions. The first is that it's responsible for certain aspects of memory, related in particular to the context of memory or the emotions around memory. So essentially, it helps us to consolidate important memories. And that makes sense in the context of the stress response, because you want to remember if the line is important in terms of a stressor. There are other things that we think aren't so important, and therefore they might not be as well consolidated. So when there's hypervigilance and hyperawareness and an elevated stress state, because of those high levels of cortisol, the hippocampus lights up and it starts to consolidate the memories that are occurring in that moment. Now, the hippocampus also has other functions, and one of the most important is that it has direct dendritic input into the hypothalamus. And as hippocampal activity increases, it acts as a brake on the hypothalamus. So this is one of the ways in which the HPA axis becomes regulated, so that as cortisol levels climb, they don't climb too high. And so as hippocampal excitation is occurring, we begin to see a moderation of the HPA axis, as well as more modified levels of cortisol production as a result. Now, don't forget, cortisol is a catabolic hormone, and that means it breaks down tissue. So we can see times when people have overwhelming stress, and that can cause alterations in hippocampal excitation to the point where the hippocampus starts to function abnormally. That means that we don't have as great ability to consolidate memories. We also lose the regulatory function into the HPA axis, which ironically means cortisol levels tend to climb even higher. And under the worst circumstances, because cortisol can be so injurious to tissue, over time the hippocampus begins to break down. So it goes from a hyperexcited state to one of retraction, and ultimately volume loss and even scarification, or what we call atrophy. So it turns out there's a very high correlation in individuals who report symptoms of PTSD with a small hippocampus. And that's a terrible place to be, because it means that we've literally injured a component of our brain because of overwhelming stress. Now, the cortex has cortisol receptors, so that's responsible for executive decision making and high-level cognitive function, in addition to the amygdala, which is important for emotional stability. And when we begin to see changes in amygdala activity, and usually a swelling or interstitial edema of the amygdala, we then see higher levels of anxiety as well as irritability and reactivity. So ultimately what can happen in prolonged or high states of stress is hippocampal atrophy, atrophy in the cortex, as well as volume increase in the amygdala. So what patients tend to report is memory disturbance, poor decision making, emotional irritability, and loss of response to stress. And in addition to all of that, because cortisol has an impact on the immune system, we see immune shifts as well. Now remember, cortisol is our natural anti-inflammatory hormone. So that means as cortisol levels climb, our immune system is suppressed. So you can see this negative sign that goes from cortisol to the immune system. That's important to recognize because it creates some immune vulnerability and a shift to Th2 status when people are under high states of stress. Now, what happens over time is that if there's prolonged stress, the brain begins to say, enough is enough. I'm going to begin to downregulate the HPA axis to prevent further injury and damage to the brain. And this is a really important idea to understand, that patients will go from a high cortisol state to a low cortisol state, which is mostly mediated through this central response of the brain, that the brain is basically trying to limit further allostatic load on the central mechanisms. So once the brain has said enough is enough, I'm turning down the HPA axis, we see a diminishment of cortisol output. And that's the neurodegenerative model of hypocortisolism. Basically, when you injure the brain, when you alter its function because of ongoing states of stress, we begin to see a lowering of stress output. So clinically speaking, when I see an individual with a flattened cortisol curve, I don't automatically think, oh my goodness, those poor little adrenals. I think, oh my goodness, poor brain. What happened to the brain? And that's exactly what you should be thinking. Because if you look at both functional MRIs, and in my own clinical practice, we evaluate our patients using structural MRIs, we can see hippocampal changes and identify when there are centers in the central nervous system that have been altered because of stress. And in addition to that, when patients end up with a flattened cortisol curve, there is a release of the immune system, that there's higher baseline levels of IL-6 and TNF-alpha and CRP, and a shift to Th1 dominance. So there's a greater likelihood for autoimmunity and cancers, basically lack of repair, because the body is now in a more catabolic state overall because of all this inflammation that's occurring. That's even worse. And even from a feeling state, when you look at the psychiatric literature, high cortisol has been linked with classical depression, or what's called treatment-sensitive depression. So when patients are hypervigilant, but the systems are still intact and cortisol levels are elevated, therapeutic interventions tend to work better, like SSRIs and SNRIs, in addition to botanicals and other natural strategies. But when cortisol levels have flattened and we see a higher baseline activation of the immune response and brain-related changes, we then reclassify these patients as treatment-resistant depression. And that makes sense because there's all of these metabolic shifts that have occurred now that are pushing the patient into a sicker state of health. So it's not just this notion of underfunctioning adrenal gland. That's small potatoes at best. What we really have to consider is what's going on with the brain and what's going on with the immune system, and how do we help rebuild metabolic reserve, rebalance the immune system, protect the brain, and modulate the stress response. There's a lot of work to be done when you identify a patient with a flattened cortisol curve, not to mention all the peripheral receptor abnormalities. So this is a much more, I think, serious state of health when people flatten their cortisol curve. And all of the clinical research tied to flattening of the cortisol curve bears that out, that we know individuals who have hypocortisol states have far worse clinical outcomes than people who have high cortisol states. And I'll talk about that as well. So this relationship between stress and neuroinflammation is so key to really more fully appreciating the systems biology idea of all of these shifts that are occurring as a result of overwhelming stress. And so just by appreciating what a flattened cortisol curve can indicate, you now have greater insight into this notion of neuroexcitation in early phases of stress, ultimately leading to neurodegeneration. And then there's this background idea of what we call structural plasticity, which is, can the brain heal over time if these activities or events have occurred? And then also asking yourself the question, if the patient has gone through these stress-related states of high and low cortisol and central nervous system changes, what's also occurring in the immune system? You have to ask the question, because cortisol is so intimately tied to immune response that you really can't get big changes in cortisol output without seeing commensurate alterations in immune function. As I said, high cortisol, Th2 dominant. Low cortisol, Th1 dominant. We also see alterations in innate immune activation, especially in early states of the stress response, as well as microglial activation. Microglial cells are the immune cells of the brain. They're essentially macrophages. And cortisol will directly trigger microglial activity, which means that there's a much greater output of neurotoxic compounds as microglial cells turn on, which is one of the main engines of injury to the hippocampus and other key centers in the brain itself. So ultimately, stress becomes a brain on fire phenomenon. And over time, one of the ways in which the brain protects itself is it turns off the stress response. And this makes sense from a therapeutic perspective, because many of the adaptogens and botanicals that we use that have been shown to help protect individuals from ongoing stress have direct capacity to limit neuroexcitation in the brain, stabilize NMDA receptors, tone down microglial activation, turn off the fire in the brain. That's essentially what a lot of them are doing. Now, they also have other properties and work on other body systems as well. But where they really don't have much impact, and this makes sense, is the adrenals. Where they're functioning, and this is what makes them so special, is they have, great clinical import on the brain itself, and they help modulate the immune system. And when you look at the literature on rhodiola, ashwagandha, ginseng, maca, cordyceps, all of these really special herbs that tend to be promoted in the setting of stress, this is what they're doing. They're balancing neuroinflammation. They're restoring tone to the stress response. They're protecting these vital organs and systems that have been invoked and challenged and injured as a result of ongoing stress. Now, as much as cortisol can be catabolic on brain tissue and shift how the immune system is functioning, of course it has impact on other body systems, such as the digestive tract. So we will also see alterations in tight junctions, breakdown in gut lining, shifts in immune reactivity, all because of the impact of stress on the gut. And the same thing that's happening in early phases of stress with activation of mast cells and increased histamine output and atopic changes, that's also what's occurring in the gut as well. And so the gut becomes leaky, tight junctions are breaking down, there's greater histamine output, and so patients will be developing dysbiosis, food reactivity, as well as allowing foreign compounds across the gut lining to encounter the immune system. And now the immune system is functioning in abnormal ways because of these greater alterations. So there's really no body compartment that is immune to shifts in the stress response. So it can not only push the gut, but it also can create changes in the endothelial lining of the cardiovascular system. And as I mentioned, it creates alterations in reproductive hormones and parasympathetic tone, and we can go on down the line. But for our purposes, I really want you to focus on this sort of idea of the neuroinflammatory circuit that is central to its participation in the stress response. So again, repeated stress affects the brain function, especially within the hippocampus because of these high concentrations of cortisol and NMDA receptors. The hippocampus participates in verbal memory and the context of memory. Impairment decreases the reliability and accuracy of contextual memory. So once we injure the hippocampus, we can't tell the difference anymore between what's a threat and what's not. We also know, as I mentioned, damage may exacerbate stress by preventing access to the critical information that's needed to decide that a situation is actually a threat. So we can't tell what we need to react to and what we can't, what we don't need to react to because of ongoing stress. And the hippocampus regulates the stress response and acts to inhibit the HPA axis. So changes in the hippocampus, so alterations in structure and function have been identified in long-term stress. And as I mentioned, we see volume loss in patients with PTSD, depression, and Cushing's syndrome as they're going through high cortisol levels and then ultimately low cortisol levels. So with volume loss, that's when there's this trigger of, oh, the brain says enough is enough. I'm going to turn down the stress response. And there can also be functional changes, which include reduction in hippocampal excitability, long-term potentiation related to memory. So this notion that the hippocampus first swells because of neuroexcitation and NMDA receptor activation, but over time it begins to shrink and shrivel and atrophy. And there are circumstances where the hippocampus probably becomes permanently injured, that there's really nothing we can do to get it back. Now, the hippocampus has a very interesting mechanism, though, to protect itself from full atrophy. And this is this newer idea of what's called dendritic retraction. This is such an important phenomenon. And what this means is that under high states of stress and cortisol and neuroexcitation, we see shrinkage of these apical dendrites in the CA3 and CA1 pyramidal cells and dentate granules. And so what's happening is the neurons are changing their shape or morphology, which can contribute to alterations in how our brain functions, meaning memory and cognitive deficits. So we get this functional outcome of volume loss due to disturbance of this HPA axis, which leads to unregulated glucocorticoid release. Now remember, when the hippocampus changes in function and structure, we lose its brake on the HPA axis. So actually, unfortunately, cortisol levels tend to go higher, which leads to increased oxidative stress, further neuroexcitation, and loss of counter-regulatory control. So this is really important to understand that dendritic retraction is volume loss where we see lack of branching in the dendrite. And so normal hippocampal dendrites are beautifully complicated with lots of branches like a full mature tree. But what happens over time is as we saturate those dendrites in cortisol as well as neurotoxic compounds from microglial cells, the dendrites start to shrivel and actually align. And instead of branching, they look like lines on a page. And this is a strong indication that they're protecting themselves against further injury from all of that hyperexcitation. Now, under some circumstances, if we remove the insult, if you stop the stress, if you turn off microglial cells, we see a rebudding and a reblooming of these dendrites. That in fact, there's volume growth and therefore regeneration that's occurring of those hippocampal areas of the CA3 and CA1 region. That's possible. Now, there is a cut point, and there are some patients where that's not possible. And that, in fact, is just scarification and true atrophy. We can't tell based on structural MRIs what's dendritic retraction and what's atrophy. Now, we want to help protect the brain, even if it's in this retracted state, by turning off inflammation and limiting excitation, because that's our best chance of, over time, helping the brain heal and repair. This is so important to understand. So neurons need to protect themselves from the excitotoxic effects of glutamate by reducing their input surface area. So we want to stabilize those NMDA receptors, make sure there's not too much calcium influx into the neuron. So this is essentially what happens under those high states of cortisol: accelerated neurodegeneration, turning off the brain's ability to heal itself, meaning limiting adult neurogenesis, hippocampal atrophy, loss of hippocampal regulation, decrease in memory and cognitive function, and alterations in the prefrontal cortex, amygdala, and locus coeruleus. So all of this is occurring under states of stress, in addition to the brain-related changes. So once you take out the hippocampus and we see flattening of the cortisol curve, things really just get worse from there. So clinically speaking, a systems biology approach is so important because patients can report states of stress. They can talk about their symptoms related to that. You can even identify when they're losing their coping skills and emotional resiliency. But then we can measure components of this and say, look, you flatten your cortisol curve. We see changes in your immune response. You now have the presence of food sensitivities and alterations in endothelial function and cardiovascular system. I see changes in your reproductive capacity and lowered sex hormones. These are all metabolic shifts that are underlying a progressed stress response. There's a lot of work to do, therefore, to help these patients heal. So stress then really, therefore, has this global effect on the brain, on the immune response, and on the gut, for example, as well as other body systems too. Just about every physiologic process can be influenced by ongoing stress. And it makes sense because even when you look at inflammation research and how it underlies many chronic illnesses, and you map that to all of the chronic conditions that have also been linked to chronic stress, it's almost identical. And so whether cortisol levels are high or low creates alterations in the immune response and greater emphasis on the relationship between inflammation and these chronic illnesses. Even worse when you flatten your cortisol curve because you're unhinging the immune system, which means that it's more unregulated and therefore has a greater impact on these chronic illnesses. So not only does stress have a direct impact on in immune cells, but there's also a secondary pathway by which we see alterations on the immune response, and this is through the sympathetic chain. So there's increase in sympathetic dominance related to stress as well. And interestingly, as epinephrine and norepinephrine levels are climbing, we see higher levels of inflammation. So what's happening is when cortisol levels are up, we see a central suppression of the immune response, but then there's an alteration at the tissue level based on sympathetic dominance, where actually the tissues themselves are more inflamed. So there's central lowering of IL-16, F-alpha, and CRP, but there are changes in the peripheral tissue where we actually see a heightened immune vigilance. And so this really gets into, well, what are the components of the immune system that are influenced by stress? Well, there are two main partitions to the immune response. There's the innate immune system and then the adaptive immune system. The innate immune system is the early primal component. It is non-specific. It's what contains macrophages and microglial cells and neutrophils, and it's the early responders on the scene of the crime. The adaptive immune system is much more sophisticated. It's the newer component. It's where T cells and B cells originate. This is how we marshal memory cells as well as an antibody response. And there are subcomponents of the adaptive immune system, such as T cells and T helper cells in particular. So you can see Th2 response with cortisol levels, high cortisol levels. We also see Th1 response with low cortisol levels. The newer kid on the block is Th17 and even Th22 for that matter. And then finally, T regulatory cells, which are so important to help rein in peripheral tissue activity, especially with these Th17 cells, and help to balance Th1, Th2 activity. So our understanding of the complexity of the adaptive immune system has increased, but there is an absolute impact of the stress response on the stance of the adaptive immune system in particular. Now, back to the innate immune response, we see activation of these microglial cells in the brain. So as cortisol levels climb, they start spilling these neurotoxic factors and compounds, which unfortunately begin to injure local dendrites. And as those neurons die, the compounds that are released become microglial activators, so we see enhanced inflammation. So there's this kind of pro-inflammatory trigger that's occurring that results in these cumulative effects in the brain. In addition to that, as I mentioned, there are alterations in the gut, and this is a really important slide to understand with relationship, and really, I think, putting a fine point on how cortisol influences the stress response. So in the left-hand column, you can see this is an individual with irritable bowel syndrome who's under high states of stress. So they have high cortisol levels. And at the same time, in colonic tissue, there's an activation of Th2, as I've mentioned. So they have high levels of tryptase and histamine, in addition to overexpression of IL-4, which actually downregulates Th1 activity. That's a very functional idea of irritable bowel, that usually these patients are hypervigilant, they self-report high levels of depression, but they're Th2 dominant in the gut. All makes sense. Now, conversely, let's look at the middle column, inflammatory bowel disease. So when there are systemically high levels of inflammation, as a result, there's blunting of the HPA axis, so there's less output of cortisol, which makes sense. When we look at colonic tissue itself, it's Th1 dominant with higher levels of TNF-alpha, IL-1B, and IL-6. And by virtue of that, interferon gamma begins to suppress that Th2 activity. So, makes sense. Now, what happens if you take an irritable bowel patient and you injure their stress response? Well, if they end up with a blunted cortisol curve and they have a flattened output, now we've liberated the immune system, and we can see a shift from Th2 to Th1 dominant. So even if you're irritable bowel, we see systemically and locally in the colonic tissue higher levels of TNF-alpha, IL-1 beta, and IL-6. So basically, when you change the stress response and you induce a flattening of the cortisol curve, you can actually further promote higher baseline levels of inflammation, even in the setting of classically non-immune related conditions like irritable bowel. And so this to me is a very profound idea that, once again, if you flatten your cortisol curve and you liberate the immune response, it's far worse for the individual. In addition to that, there's also the neurodegenerative hypothesis of depression, that in fact stress creates alterations in the digestive tract where we see elevated levels of pro-inflammatory cytokines, which triggers what are called indolamines. These are enzymes in the digestive tract that are responsible for the production of serotonin. As many of you probably are aware, 95% of serotonin is actually made in the digestive tract and makes its way to the central nervous system. Now, if we see upregulation of indolamines because of stress in all of its forms in the gut, and this includes medicines, toxins, infections, dysbiosis, poor food choices, all of the things that act as sort of a metabolic stress on the digestive tract, we see a shunting away from serotonin production within tryptophan metabolism down the kynurenine pathway with excess expression, typically of quinolinates or quinolinic acid, which further accelerate neurodegeneration. So the gut produces quinolinates, which also alter the central nervous system and has been linked directly with major depression. So this is another mechanism by which the gut becomes an engine of toxicity, an engine of inflammation. So this to me is so critically important because, once again, stress can influence certain body compartments and accelerate injury to the brain. We can do it because of the just general stance of the immune response within the gut, which has feedback loops to the brain, which changes how we think and feel. This also, through sort of a secondary pathway, can occur because of excess quinolinates, which are also neurotoxic. So it's almost as if as the body begins to break down over time, no wonder people don't feel well. No wonder they lose resiliency. No wonder they have anxiety and depression. No wonder their memory isn't so good, because the brain takes hit after hit after hit. And so our job is really to help people sedate the stress response, balance the immune system, seal up these linings and barriers like the gut and the endothelium and the cardiovascular system that are beginning to degrade, because the immune system is there waiting for those changes. And now it's further upregulated, especially if you alter your cortisol curve, and it's even hypervigilant. And so this really leads to a metabolic mess in patients. So when I think about flattening of the cortisol curve, I think about all of these features of what may have occurred in their metabolism. So when you see a lowered cortisol response, basically breakdown of allostasis, and the patient is now in this low allostatic load state, we know they have higher levels of systemic inflammation with microglial activation, serotonin degradation, and non-specific symptoms of sickness. So flattening of the cortisol curve as patients migrate from high to low means that their systems are getting worse. They're soaking up their reserves, and now they're even sicker. And this makes sense when you look at outcome studies. Now, you might think, well, Dr. Heyman, is it just emotional stress that can lead to a flattened cortisol curve? And the answer is no. So here's a very provocative study, and there's a variety of these like them in the literature that I wanted to point out. Here's one by Raisin and Miller that they report. They assume that prolonged or repeated exposure to immune stimuli might predispose an individual to reduced glucocorticoid signaling as a means of freeing bodily defenses from the inhibitory control in the face of an ongoing infectious threat. So, wow, what does that mean? If you see a patient with a flattened cortisol curve, sure, you may ask yourself the question, did I get here because of overwhelming stress and brain-related changes and alterations in the systems throughout the stress response to protect itself from further stress? Or, as this study suggests, is it because the body has encountered some sort of infectious threat, a vector, an immune compound, or a lectin that it can't fully deal with and handle? So it will purposely turn down the stress response to liberate bodily defenses so that it has a better capacity to deal with this threat. Wow. So in fact, the body is so smart, it will induce a hypocortisol state to liberate the immune system, to add more energy into immune cells so they can do their job better. So thus an enhanced release may be beneficial for health and survival. Most strikingly, the demonstration of a low allostatic load index in hypocortisolemic subjects, meaning a flattened cortisol curve, suggests that a downregulation of the HPA axis in chronically stressed subjects protects those subjects against the harmful effects of a high allostatic load index, meaning that the body has decided it's better to flatten the cortisol curve and take on all the consequences and symptoms of that to deal with the infectious threat. And it's decided that this may in fact be beneficial for patients over time. So that's a real head spinner. Dr. Heyman, patient has flattened the cortisol curve. Are you telling me that the body's doing this on purpose because it's trying to deal with an immune threat? Yes. As a practitioner, are you asking yourself that question? Are you saying to yourself, boy, this patient has a flattened cortisol curve, they feel terrible. Of course they have fatigue, but is that because they've had overwhelming stress? Or is it because the body was so smart, it's turned down the stress response to turn up the immune system? And that in fact, this stance is adaptive, that it's done this on purpose. And think about that. In both circumstances, the neurodegenerative model of flattened cortisol curve, meaning I've had overwhelming stress, the brain has said enough is enough, I'm turning down the stress response. It actually indicates that a flattened cortisol curve is adaptive, that it's a good thing for the body. Now, when we talk to patients, we say just the opposite. We say, oh, Sarah, you flatten your cortisol curve. Isn't that terrible? No wonder you feel so awful. And your poor little adrenals, we have to do everything to stoke the fire of the adrenal glands. So here, take these glandulars and vitamin C and B vitamins and so on and so forth, and let's get your adrenals back online. Where the body has said, you know what, I'm turning down the whole system because I can't handle any more stress. And conversely, Sarah presents to your practice with a flattened cortisol curve. Are you asking Sarah, hey, maybe we should check you for infections and biotoxic exposures? What do you think about that, Sarah? I mean, do you live in a moldy environment? Have you been bit by a tick? Do you have other infectious threats and vectors like Epstein-Barr virus or CMV or HHV6 that are contributing to this low allostatic load state? And what I found is that in a subpopulation of patients where that's how they present, if you treat the bugs and re-regulate the immune system, cortisol levels come back up. Amazing. Incredible clinical insight. This study alone, for me, was a huge wake-up call to say, you know what? The body is smarter than me. It will turn on and off certain systems to be able to deal with pressures and threats. And so, again, just like what Dr. Lachine says, we need to integrate facts. We need to put them in a context. Just because cortisol levels are low does not mean that this is an abnormal state of adrenal function. In fact, it likely doesn't mean that. It means something broader and deeper and more important. And so we have to be sophisticated in the way that we think about changes in the stress response, what it means for the patient based on their symptoms and labs and so on and so forth, and be a bit more strategic in how we deal with them. So, key points. Models of hypocortisolism. There's the developmental model. So stress overwhelms the brain. It overwhelms the immune system when we see a downregulation. And then there's the immune-mediated model. So therefore, there's an infectious threat or vector, an upregulation of the immune response by virtue of downregulating cortisol levels. In addition to that, prolonged cortisol production is neurotoxic, not just to the brain, but other body systems. And of course, there's a reciprocal relationship between the immune system and the HPA axis. So once again, hypocortisolism may be an adaptive mechanism to protect the nervous system. Amazing. So, central mechanisms of low cortisol output. There's reduced biosynthesis of releasing factors or hormones in the HPA axis. We can see a decreased or increased target receptor sensitivity, hippocampal atrophy, hypersecretion of secretagogues with downregulation of target receptors, and just about every body system is influenced by the stress response. And it makes sense. Look, stress is meant to save your life. That's what it's designed to do. Whether you flee up a tree or fight the tiger, it really is one of the most important bodily responses. That's why we're so hypervigilant to stress. It is an ancient reaction, and it's designed to save your life. So no wonder cortisol receptors are found all over the body. So once again, cortisol has an impact on immune system and can lead to significant dysfunctions. We see inadequate immune cell trafficking, inability to defend against pathogens, inadequate leukocyte trafficking, elevations of immune mediators, especially in low cortisol states, like IL-6 and TNF-alpha, overexpression of prostaglandins, lymphocytes, natural killer cells, autoimmune antibodies. And in the cardioendocrine system, we can see accelerated progression of atherosclerosis, risk of MI and heart failure due to elevations in inflammatory markers like PI1 fibrinogen and hsCRP. There's a direct toxic effect to the endothelium, which can lead to hypertension and endothelial dysfunction, as well as enhancement of insulin resistance and hyperglycemia. Now, what does this look like more through a clinical lens? So let's take a look at the Cardia study, which was published in 2006. 718 black and white middle-aged men. They did a 6 salivary cortisol sample and then measured their coronary calcium score. And persons with the cortisol slope in the flattest quartile had the greatest likelihood of any coronary calcium than did those in any of the other quartiles, and adjusted for all sorts of factors. Now, what does that mean? It means that the flatter the cortisol curve, the more coronary calcium they found. And the flattest quartile had the most calcium. And that makes sense. Why does calcium get laid down in arteries? Because of inflammation. And inflammation levels are going to be highest in the flattest quartile. So amazing. They actually do, when you look at research studies, they will often do regression analyses on the slope of the cortisol curve. Flattening of the curve means damage to the HPA axis, which means you've liberated the immune system. So what are the symptoms related to low cortisol? Well, pretty predictable. Fatigue being the primary, sensitivity to stress, probably from that enlarged amygdala and changes in the cortex, and then pain. So the hippocampus and the hypothalamus stand right next to the endorphin centers of the brain, and so patients have typically centralized pain-related syndromes, and so we see clinical expression of this through chronic fatigue, fibromyalgia, and elements of PTSD. So from a diagnostic perspective, what does this output look like on cortisol? Well, the best tissue sample for measuring cortisol still is saliva. I actually think now urine is pretty good too, but the key feature of this is the pattern, and pattern matters in looking at cortisol output. As I said, there's a diurnal pattern. It's high in the morning and lower at the end of the day. And there are often various patterns that you'll see in patients when you measure their cortisol output. But you really want to measure over the course of a day. So what are some common abnormal patterns? You'll see elevated cortisol levels, depressed cortisol levels, and mixed cortisol levels. So this is a normal pattern. High in the morning, and then a significant drop to midday, and then a slower decline to the evening. And this represents a healthy stress response. Now, this is not someone who's under stress as we measured it. You'd see high cortisol levels if they had a stressful event, but in a normal daily state, this is what we see. And the reason why cortisol levels are so high early in the morning, usually they start to climb even before we wake up, is because cortisol enlivens the brain. It excites the central nervous system. It says, hey, get ready for the day. Get out of bed. Get going. Turn on bodily systems so that you can have plenty of energy and deal with your day. And then cortisol levels decline, but of course they'll go up if you have stress. Now, this is an individual who has very high cortisol levels throughout the day. This is hypervigilance. This is treatment-sensitive depression, wired and tired. But you're also getting all of that central activation, microglial excitation, NMDA receptor triggering, and also all the catabolic effects of high cortisol. And now you could say, wow, Dr. Heyman, now I get it. High cortisol levels, it means brain is on fire, injuring the hippocampus, degrading the gut lining. I have alterations in my cardiovascular system. I'm depressing my reproductive hormones. I'm shifted into Th2 dominant state with central suppression of the immune system. All of these things are happening as a result of the high cortisol level. Now, as the brain and the rest of the body is starting to say enough is enough, we begin to see a mixed pattern. We might see very low levels in the morning and then elevated levels throughout the rest of the day. And this is, a further progression from the hypervigilant state. And then unfortunately, hypocortisolism, a low in fat stance of the HPA axis, means a low allostatic load state. Bodily systems have been overwhelmed. There's a liberation of the immune system and all the consequential factors that arise from that. And you can ask yourself the question, did the patient end up here because of the neurodegenerative model where the brain has said enough is enough, or did the patient end up here because of an immune-based threat? You always have to ask yourself those questions. So these diagnostic assays are really important. That flattening matters. It's the most predictive of the stress response. It's the most well-studied. And hypocortisolism induces intensified immune vigilance, elevated levels of IL-6, and therefore fatigue. Now, in a more clinical context, we also know that patients who have a significant illness in the setting of a flattened cortisol curve always have worse outcomes. I have not found a single study that says otherwise. So here's one on flattening cortisol rhythms in metastatic breast cancer patients. What they found is that women who had a diagnosis of breast cancer with an associated flattening of the cortisol curve had worse morbidity and mortality. They had higher levels of metastases and early mortality compared to women with a normal stress response, which means, number one, it makes sense. If you have higher levels of IL-6 and TNF-alpha, you're going to progress your cancer. They're going to have higher rates of symptoms, and also early mortality. So I always measure cortisol patterns in my cancer patients because I think the pattern matters. We also know because when levels of cortisol are low, and conversely, levels of IL-6 are therefore high, when patients report fatigue, we're not even sure if that's from the low cortisol or the high IL-6, because we know when IL-6 is elevated, people tend to report high rates of fatigue. So pattern matters. When you flatten your cortisol curve, there's metastases and early mortality from cancers. We see early heart failure and MI and atherosclerosis. Patients are more likely to die from the MI if they have flattened cortisol curve, and they have worsened glucose control. So this makes sense that flattening of the cortisol curve with changes in the immune system and changes in the brain can relate to real clinical endpoints. This is not just this notion of, oh, poor little adrenal glands. This is serious stuff. This is a real medical condition. This patient has progressed from an early stage to a late stage change in their stress response, which has dire consequences potentially on a variety of not only bodily systems, but also can influence disease outcomes. So how do I protect the brain? Well, we want to induce neurogenesis. We want to enhance the brain's ability to protect itself. So neurogenesis refers to the production of new neurons in the adult brain, which follows a similar complex multi-step process that starts with the proliferation of progenitor cells, followed by the morphological and physiological maturation, and we end with a fully functioning neuron. And so there's a sequence of events that begins with those early stem cells. They proliferate, we cultivate them, they mature, and eventually we have these beautifully budded and branched dendrites. And there are certain mediators, though, of adult neurogenesis. So stress and sleep disruption can alter the capacity for neurogenesis in the brain. Stress interferes with all stages of neuronal renewal and inhibits both proliferation and survival. And there are glucocorticoid and NMDA receptors that are on these progenitor cells, which means that you can even have lasting inhibition of adult neurogenesis long after the stressor has gone away. So that means that you can shock these progenitor cells because of significant stress. So to begin to sort of encapsulate all of this, cortisol has an impact on the brain. We see NMDA excitation because of excess glutamate production, calcium influx, which is neurotoxic, reduced neuroplasticity, and an imbalance between the sympathetic and parasympathetic nervous system. There are shifts that occur in Th1, Th2 balance with microglial activation, and ultimately liberation of IL-6 and TNF-alpha in flattened cortisol states. Stress can also enhance gut permeability with activation of those indolamines and therefore degradation of serotonin. So what are some of the things that I think about? Well, this is the list. When I look at patients who have ongoing stress, I ask myself the question, what is their cortisol curve like? Is there a good explanation for why their cortisol levels are high or low? Is it psycho-emotional in origin? Is it historical? Is it contemporary? Or are there other features of what's going on in their life that might suggest we should look at additional exposures and threats that have altered the stress response? So I think about cortisol, the NMDA excitation. So how do I blunt glutamate in the brain? How do I encourage neuroplasticity? How to restore harmony and balance in the autonomic nervous system by enhancing heart rate variability? How do I create balance in the immune system and sedate microglial activation, and then seal up the gut and make sure that we don't have extra pressures that are forcing the immune system into a heightened vigilant state as a consequence, ultimately, of an abnormal stress response. This is a lot to think about, but now we're putting stress in context. It is not an unintegrated fact anymore. And my criticism of the term adrenal fatigue is that we're actually functioning in some ways like normal practitioners. We say, oh, cortisol levels are low, let's raise it. Well, there's consequences to that. If you raise cortisol, do you think it further injures the brain? Yes. If you raise cortisol and the body's trying to deal with a microbe or pathogen, do you think you're doing the pathogen a favor? Yes. If you don't look at the stance of the central nervous system, the immune response, and all these other related bodily processes, and you just focus on this notion of dealing with the adrenals and raising cortisol levels, do you now think you might be missing some unintegrated facts? And the answer is absolutely. Why? Because the body is a system of systems. And this is what's been observed over thousands of years by traditional healing systems from around the world. That as you become a CT scanner and EKG machine, as you more fully appreciate the pattern of expression of abnormalities that will come off your patient, you can then begin to capture these related changes because the body is a tightly integrated set of subunits. And that as we push on the stress response, there will automatically be changes and alterations in other body systems. And so this should dictate how you think about your patients and your treatment selections, that you're going to work around these issues to protect the brain, balance the stress response, restore harmony to the immune system, and look for those secondary and tertiary consequences. That this is a very multimodal intervention when we see alterations in the stress system. And again, I would always suggest that you draw your attention to how is a person thinking and feeling, what's their cognitive capacity, what's their memory, what's their pain levels, what's their levels of fatigue, and then also measuring components of the immune system to see what is their stance there as well. And then also thinking about other features of an abnormal stress state, not just the consequences in terms of gut function and cardiovascular function and reproductive hormones and so on and so forth, but also how else did the patient get here? Was it just from stress, or is it some other threat and vector or some other feature that their body is trying to contend with that has ultimately influenced the status of their stress response? So I know this is a lot to absorb. I want you to sit with these ideas. I want you to think about these interrelationships. They have great clinical import for you. And it should really fundamentally alter how you think about your patients and what you're going to do for them with respect to your treatment choices. I will also be talking about several therapeutic strategies related to some nice dietary supplements that Da Vinci has put together for us that help to balance these issues and restore harmony to the stress response and other bodily processes. And I think they're wonderful agents to begin to deal with this complex topic. So thank you for your attention and time. I hope this was helpful for you to recharacterize how you think about the stress response so that you don't have so many unintegrated facts, that we appreciate that the body is a system of systems, and that this should offer us new insight in how to think about stress, but also develop new clinical strategies to create success for your patients. And I look forward to speaking to you again in the near future.